Hi, welcome to Roll Call. I'm Jeff. Today we're going to have Samantha Lane with us, who's an infection protection specialist, and Chief John Father sitting in the studio. Sam, how are you doing today?
Good, thank you.
Tell us what you do real quick.
Okay, so I'm one of the infection prevention specialists here at Charles Regional Medical Center. So a lot of what we do is we make sure that we're preventing the spread of infection anywhere throughout the hospital, and making sure that workers are protected, the patients are protected, and also doing surveillance monitoring routinely, all of the time.
Tell me more about that surveillance monitoring.
Well, surveillance monitoring is there's lots of pieces to it. There's we do monitor COVID definitely all the time, but we also are monitoring hospital acquired infections. Staff, we want to make sure that we're not our staff is being protected, so they're wearing the appropriate PPE whenever they're in any type of room that a patient may have TB or meningitis, and we're constantly monitoring and doing surveillance and watching for all of these any potential infection, including outbreaks, and of course here we are into a pandemic, and now we're monitoring that constantly, watching test results, giving information to the local health departments, the state health department, along with anybody who may have come in contact with those particular patients, like EMS staff. And then, of course, we forward most of the information to the health department, and they do contact tracing.
Okay. Chief, I didn't forget about you. How are you doing today?
I'm doing good, Jeff. Thanks for asking. So Sam was the weather. The weather is amazing outside now that it stopped raining. Hey, I got
a question.
No, I want to let you know Sam was being a little humble. She actually is very important to our department because and the county at whole, because she is the contact who calls me every single day to let me know who had a COVID positive patient or not. So sometimes she calls me twice a day to let me know. And I think at the peak she called me like 3 times a day. Although, Sam, you didn't call me today, so it's either a good thing or you were just waiting for the podcast.
No, it was actually a very good thing. In the last 24 hours, we have not had a positive COVID-19 patient come through.
Oh, wow. That's good. That's happy Friday news.
Sam, you were talking about your infection control procedures you had. Tell us, you obviously had a lot of this in play before the COVID outbreak. Can you tell us a little more detail of what that would entail, and how would you treat a patient who was, in fact, TB positive?
Okay. So, for instance, let's say, the patient comes in through the emergency room. They identify the fact that the patient may possibly have TB. That we're going to put them in a negative pressure room right away. Staff are going to wear the N95 mask or the PAPR when they enter that room. We're going to keep that patient on negative pressure during the entire time the patient is here as we're working them up. Again, we don't know, we can't say right when they walk through the door that yes, they are TB positive unless we know that ahead of time. But if they have signs and symptoms, we're going to go ahead and isolate them, making sure the staff wear, like I said, airborne protection. And then if the patient leaves the room during any time of that visit, the patient's going to have on the face mask. Like, let's say they have to go to x-ray or they have to go to a CT scan. The patient would wear the mask during that transition, not the staff. But if the staff go into that patient's room and they're in negative airflow, the staff wear the N95 or the PAPR. Once we do discover that the patient truly does have TB, then we would go ahead and notify the health department. We would also, at that point, notify anybody from EMS that may have been exposed if the patient was brought in via ambulance, and just continue to keep the patient on isolation until we have negative results, and then we can take the patient off isolation after the patient's been treated.
I got you. Okay. Tell me a little bit about negative pressure rooms. How many do you have at Charles Regional?
We have 16 negative pressure rooms. Each of them has a certain amount of airborne removal of contamination, where it cycles through maybe between 6 and 12 cycles per hour to get the airborne contamination out of the room. Like I said, we have 16, but with COVID-19 patients, kind of how it works is you want to place that COVID-19 patient in a negative airflow room if you're doing aerosolized generating procedures. If you run out of negative airflow rooms, then what we're going to do is we're going to put that patient in a private room with the door closed, and we're going to put a HEPA scrubber in the room to help filter the air.
Okay. Very good. Yeah, I'm familiar with that sterilization stuff. Yes, I am. You had another question here. So, all right, what is the status of the testing in Charles County? Are we able to test more patients, or has it stayed the same, or has it been declined, or where are we at with that?
Well, the ability to test patients in Charles County, it has increased just like, it has, statewide and throughout the nation. We've been testing about 20 to 25 patients a day since early March. And also there is testing available I don't know if you guys are aware, through the Department of Health, and they're doing it at the vehicle admissions and inspection station site in Waldorf. My understanding that they're doing it two days a week, and they've been doing that now for the last several weeks. Of course, as we're increasing our capability of testing, you're seeing the numbers starting to jump up of positive cases. See that reported on the news all of the time. And just so that you know, it is important that you realize that, EMS workers and any healthcare workers, they are a high priority under the current guidance by the CDC for testing. However, it's not just as simple as testing anyone. We, who ask for it. We want to make sure that we're testing patients and healthcare workers that have symptoms. And, the symptoms, I don't know if you guys are aware, but the CDC changed their guidance on the symptoms. They've added a few more. So we always knew fever, cough, and shortness of breath. But they've recently added chills, muscle pain, new loss of taste or smell, vomiting or diarrhea, and or sore throat.
So they can be tested, and that's good to know. So what are some of the guidelines for this COVID-19 testing?
Under the current guidelines for tests, the highest priority, and again, the CDC actually just updated their guidance on this on April 27th. So they've put high priority on hospitalized patients, healthcare facility workers, workers in congregate living settings, and first responders with symptoms. And again, I told you what those symptoms would be. And then, of course, residents in long-term care facilities or other congregate living settings, including prisons and shelters with symptoms, and then persons identified through public health clusters and selected contact investigations. Again, another priority, of course, is to test people without symptoms. But again, that's going to be based off of the availability of supply. So if you don't have the supply, we want to test our symptomatic patients first.
Hey, Sam, I have a quick question while you're on that topic. So a lot of in the beginning, there was obviously there's a lot of unknown, which caused a panic. So people were especially they were asking us, hey, why can't we get tested? I was exposed. I heard so-and-so had it. I just want to get tested. And I would tell them, well, you can't get tested until you're symptomatic. And they would always say, well, why do I need to be symptomatic? Can you explain the need for a viral load? Because you could probably do it way better than I can.
Yeah, because, you may have had an exposure, but you may not develop symptoms. Most people develop symptoms between 2 and 14 days after the actual onset of the exposure. But what's going to happen is you're going to go and get tested. You have no symptoms, and more than likely you may have a negative result because your viral load just isn't high enough yet to actually show up, because testing is based on active infection, and your viral load needs to be a certain amount for it to actually show up positive on a test. At this point, when we get to the availability of doing antibody testing, then we'll be able to see whether or not maybe you've already had an infection and now you've built antibodies to it and you have maybe some type of immunity. Again, like you guys have probably seen on the news, we don't always know what that level of antibody needs to be to actually have immunity. If we start testing everybody regardless of symptoms, your test probably possibly could be negative, and then we've just wasted the resources that we have available at this moment in time. It's better to get tested when you actually have symptoms, because we just don't have a lot of testing capability at this moment.
So when you do test the patient, that's obviously blood work. What is it you're looking for in the blood that will show that they are infected? Is it the white blood cells, red? I mean, which is it?
It's the antibodies. When we do get the capability of actually doing a blood test, right now we're doing nasopharyngeal tests, so it's just a swab, a nasal swab, and that's what we have the capability of doing right now. But when we do the actual blood test, we'll be testing for antibodies that your body will produce that will show that you have immunity, or possibly could have immunity. We don't know what that level needs to be yet.
So the test that you're doing now actually test for the virus itself, the nasal swab test for the virus. And that's why you have to have symptoms, because that's when your viral load is high enough where you're actually shedding the virus, correct?
Correct.
She said that so casually about the nasal pharyngeal test. And we've seen pictures of what that does, and that looks like a hell of a test.
It's brain sampling.
Yes.
Yeah, the foot bond.
Yeah. I don't think it's very comfortable, but
why does it need to go up that high into the nose?
There's just I honestly can't say 100%, but really you need to get it up there into where it actually gets back into the pharyngeal, which normal swabs like the flu and the like an MRSA screen or something like that doesn't need to go that high. Just kind of into the nose and a little bit of, but not all the way up.
I was hoping it would be like when I did my 23andMe, all I had to do was spit into a cup, and it was really gross. She's like, all right.
Well, I just lost my thought. Oh, I got it. So, Sam, but these tests, are they still like 30% inaccurate, or they became better? I'm sure with the blood, it's a better accuracy in determining who has the antibodies, the virus or not. But before, it's like 30% of false positives. Is that still true?
The current testing that we have here at the hospital, it is reproducible, meaning that we can take that same sample, send it to a different lab that maybe has a different methodology on testing, and they can reproduce that same result. Now, we're not finding that we're getting like any false positives, as that we're getting maybe, and I don't even want to say false negatives, but maybe it's just based off the viral load. There may not be enough viral load yet at this point to actually have that test show up positive. And then at the same time, if somebody is immunocompromised, it may be a lag time or a delay in actually showing that positive result.
Oh, really? Why is that? That's interesting.
Yeah, it's just we're just seeing it. I think it's just the way the immune system responds.
Oh.
Mm-hmm.
So, what would be some of those people that be immune compromised?
So it's going to be probably an HIV patient, somebody who's a cancer patient that's on chemo, anybody who's on any like maybe they've had a transplant and they've got medications that they're taking to alter their immune system. So those type of patients, their immune system isn't working the same way that ours is. And so then the way they react and their body responds is different.
Okay. Did we miss anything? Is there anything you need to cover?
Well, no, I just making sure, again, like when your staff are out and about and they're in the field, and I'm sure that you guys already know this and you're already doing it, but, if you do have a patient that is in respiratory distress, take into consideration that patient probably could be infected with COVID-19 and that you are taking the proper precautions. You're, wearing your PPE appropriately, that you're cleaning, you're doing hand hygiene, because, again, what's your number one mode of transmission is everybody's hands. So hand hygiene, just thinking about when you're touching stuff and you're usually, touching those high touch areas, those, even this, if I don't know how you guys do it with driver, if they initially go inside and help, but then you're coming back out, you're touching your steering wheel, you're touching everything, just making sure that you're wiping everything down constantly, and anything that multiple people are touching, like for instance, a phone or a walkie-talkie, and you're touching that, somebody else is touching that, that you're recognizing that, and you're cleaning that constantly. And then, at your guys' stations, if you're sharing the same phone, that you're wiping down those phones all of the time. If you're using the same computers and you're sharing them, you're wiping them down. If you're eating together, and I don't know if you guys have a universal masking policy when you're actually at work where everybody has a mask on all of the time. If you do, and you're actually eating in a break room, making sure that you're trying to stay 6 feet away from each other, doing that social distancing while you're eating, and everybody doesn't have their mask off at the same time.
We are doing that.
Okay, good.
Yeah, we had an order come down to us that we're supposed to be wearing our fabric masks when we're in a station around other personnel. And if we're going to eat in the same area to maintain the social distancing, or to eat in different shifts, so you're not everybody crammed in the room at the same time.
Yeah, that's perfect. Mm-hmm.
Okay.
Hey, speaking of fabric masks, I have a question for you, Sam. Okay. So it went, obviously it went, COVID patients or patients under investigation, they were N95s. And then it went to, no, you can wear simple face masks. And then it went back to N95s. And now it's cloth masks for everybody. Are cloth masks making it? I mean, help me out here.
Yeah, I know. Well, obviously, the supply is really one of the things that is, changing the CDC's guidance a little bit, because, supply affects, what we're doing here as well. So initially, when, COVID came out, it was initially thought that it's airborne droplet contact. Everybody needs an N95 mask, a gown, gloves, and a face shield. As time has kind of gone on, the feeling is, as long as you're not doing an aerosolized generating procedure, a face mask and a surgical mask are protective. And then the cloth mask is really for the person that might be sick, or anybody who's not working in the healthcare field, or an administrative person. So if you're in an office and the cloth mask is helping contain my secretions so I don't spread them. As a healthcare worker, and when you're actually near a patient, you want to either have an N95 mask on or a face mask with the face shield whenever you're within at least 6 feet of a patient. And if you're doing an aerosolized generating procedure, you want to make sure you have the N95 mask on, which I don't know what you guys have the capability of doing in your ambulance. But if you're intubating a patient, then you should have an N95 mask on and a face shield or some type of eye protection.
We don't wear the fabric masks on our calls. We wear the N95. You
wear the N95? Okay.
That's correct. So just to be clear, the cloth mask does not prevent you from getting the COVID-19. It prevents you from spreading it if you, in fact, have it.
Correct. Yes.
So we're wearing it because we love everyone else.
That's the truth, too. That's exactly what it's protecting people. That's exactly what's doing that.
Yeah, and it should be, it should be noted that the Board of Ed, the students from the Board of Ed were so cool, and they made us face shields. And so, we have them available now. So if anyone needs one, just make sure you get it through logistics. But we have face shields that the Board of Ed made us. So they 3D printed them, and they're actually pretty cool. And I got to be impressed with the ingenuity of our Charles County Public School students who wanted to do something and reach out. So shout out to them.
I'll be making that phone call.
Yeah, you need one. They're pretty cool, man.
Yeah, I do. I have one face mask now, but the goggles start fogging up on them continuously. It makes things a little difficult to see what you're doing.
So,
all right.
Go ahead, Jeff.
No, go ahead.
Well, I got a follow-up question, Sam. Am I running out of questions?
Sorry. Oh, no. Go ahead.
Okay. All right. What do you think is going to be the new normal? And I know there's no science behind this, but from your expertise, like, how long do you think masks are going to be the cool in thing? Like, I don't know, summertime's coming in. I can definitely see face masks not being the most favorite thing in the summertime. Although if you got some that matched your sandals, maybe, I don't know. You would have a horrible tan going to the beach. You'd have that, it would be like the 2020 beach tan would be that perfect square around your face.
Right. Well, I think that it's hard to say right now, but, with everything being so new. I think that probably wearing face masks is going to be for quite some time, or at least until we have some type of vaccine or we have immunity that people have, gotten from actually exposure. So until we get to that point, I think that masking is probably going to be something we're probably going to have to deal with for a little bit. Yeah. And I think that, they've talked about it, or, they get more antivirals, more medications available to actually treat COVID-19.
Okay, you wear the mask, whether it's an N95 or a fabric mask, it gets uncomfortable. The back of your ears get tore up. And they get hot, too.
Right. Well, I don't know how you guys are doing it, but, whenever you're within 6 feet of a patient, you want that N95 mask on, but you could potentially take the N95 mask off and in between, care or, when you're not actually taking care of a patient, wear a regular face mask and the face shield. But again, when you come up on the patient, you want to make sure you have that N95 mask on.
Yeah, we usually don't leave the ambulance without 95 on on an actual call. But if we're out in public, we'll have the fabric masks on. But once we're on a call, it changes everything.
Yeah. I know it's uncomfortable, and some of the, again, you want to make sure you have a tight seal, though, and I know some of the staff here, they've putting some protective, like a Duer and things like that over their skin to help protect from breakdown, from skin breakdown.
Oh, yeah, that's a good point. Yeah. Okay.
Yeah.
That's a good tip. Thanks.
Yeah, I can remember that myself.
I'm sorry. Just making sure, too, that you're not creating any break in the seal of your mask.
Right. All right. If you had to put any bit of advice for anybody listening to this today in regards to the COVID-19, what would be your best advice in them preventing themselves from getting it?
Again, I think that it's everything that they've been saying in the news, just social distancing, wearing the appropriate PPE as a healthcare worker, again, doing good hand hygiene and doing all those good infection control measures that we should be doing every day, cleaning your workstation, cleaning your home, cleaning your car. I know that your cell phone, oh my gosh, definitely. I don't even bring my cell phone into work anymore. I leave it in my car.
Really?
And when I bring it home, before I walk in the door, I clean it with a Lysol wipe.
Oh, wow. Okay.
Just because, again, it's something you're constantly touching and you're bringing it to your face. So your portal of entry for this virus is going to be, your eyes, nose, mouth, and that cell phone you're constantly bringing up to your face. And I won't even bring the cell phone to my face anymore. I only talk on speaker.
Yeah, I do the same thing. I'm weird like that. Mine's because I'm afraid of getting brain cancer from the radiation on my cell phone, even though they proved it's not a thing.
Right.
Paranoid.
But just making sure that you're cleaning your cell phone too, because again, it's touching, contact. So you're, let's just say you touch a contaminated surface, then you touch your cell phone, then you bring your cell phone up to your face. You've just, exposed yourself. I mean, granted, it's not, a huge risk as much as it would be if you were actually in with somebody who actually had it and they're coughing and breathing on you and, that type of thing. But, just being aware of everything really, that you're touching and bringing to your face and even touching your face, just trying not to.
Yeah,
I think in the flu season.
We have, that's one of my concerns is we have mobile data terminals, which are, tablet computers in all of our ambulances and fire trucks. And it's like every day someone's touching it. And I don't even know, I see what people do with the steering wheel and the gloves. I know you didn't take your gloves off.
Right.
But I can only imagine.
Right, and then,
yeah. And now they're cross-contaminating the tablet, and that tablet goes everywhere.
Yeah, and that's the thing, the gloves are only as good as you are with actually utilizing them. So, just like your hands, just making sure that, if you don't want to cross contaminate. So if you're touching something and then touching something else, that you're going back and cleaning it and changing your gloves and cleaning your hands. Mm-hmm.
Yeah, that's the routine that definitely have down there. So Kamal goes into the sink. That or some that alcohol white stuff.
Oh, well, okay. I got one more question, Sam, before we wrap.
Let me get your question. Yes, sir. Yes,
okay.
Sir.
All right. So my question is, the Spanish flu of 1918. Everyone's comparing this to the last pandemic we had in our lifetime, which actually wasn't in our lifetime because none of us were around back then. But anyway, there was the spring outbreak. There was a pause in the summertime, and then there was the fall-winter outbreak, which killed way more people than the spring outbreak. Given your expertise, what do you think? Are we in line for a fall outbreak? Is there going to be a round 2? What do you think?
Yes, we feel that this is a very good possibility, and what you're doing is also bringing flu into the picture as well. So now you got flu mixed with COVID-19 and any of the other respiratory viruses that are out there, and just regular bacterial pneumonia as well that you got to deal with. So we are expecting that, or I am particularly thinking that it's going to be a bad season. And we just want to be prepared and ready to go. And
Can you briefly elaborate on what you're going to be doing to prepare yourself for this fall?
Well, we have an infection prevention actually system group, and so as a system, we're working on what our plans will be in the future. We're not 100% sure of everything we're going to be doing yet. We're just starting to put things together. Our bed availability, you guys have probably seen our tent that's out front.
Yes.
We've increased,
yes.
increased the amount
I have a nickname
of beds.
for it.
Yeah.
I call it the bud can.
Yeah. So, and the best person to probably answer some of these questions is, our incident commander here at the hospital. He has a broader view of some of the things that we're doing as a system to prepare. Mm-hmm.
We're going to try and get him on, but he threw you in first. He said, "No, you want to talk to Sam." I'm like, "Okay, we do." So when do you think round 2 is going to happen? I just need to know so I can stockpile toilet paper and another cow.
I don't know. It's going to be tough. I think that we're, like you see them talking about on TV. I think that again, our first assault, it really seemed to hit some of our long-term care facilities pretty hard, and that's kind of what we felt. And then you could see when you do surveillance, again, like when I do surveillance and I'm looking at patients that are coming in, where do they work? You know what I mean? Like, are they healthcare workers? Do they work in an area where there's a lot of people coming together, where they're coming together and mixing, which would be your long-term care facilities, your jails, your group homes, places where there's a lot of people together in a small area. So I think that that's kind of initially what we saw, and we're starting to, and again, it's only been a couple of days into it where I'm starting to feel a little bit of a backup, and I'm not the health department, so I'm talking for the entire county that's just here at the hospital. What I feel like I'm seeing is, just more of people who are coming in contact with the general public. So now, granted, depending on your history or your comorbidities or different healthcare issues that you may have, I see people, some people who are younger who who have minor symptoms and they're fine and they can go home. And then, of course, people who have more comorbidities that are the ones that are being hospitalized, that are requiring more care and longer care. But I'm kind of concerned when they do open things back up and people start mixing, how that will affect the spread. And I'm hoping that, as the summer, we come into the summer, that things will kind of just slow down a little bit. And then maybe when the winter comes again or the fall starts to come, it will come back. But again, it will be, how are we mixing? And are there a lot of people in a small area together? And then people who are more susceptible to getting the virus and shedding the virus and spreading the virus, that I think will have problems.
Man, every time you say something, I have another question.
Does that make sense, though? Or,
Yeah.
And you guys are probably seeing it too, based off of where you're picking patients up from.
Yeah. So, look, I'm not trying to jinx anybody, but you see the numbers. Do you think we're on a downward slope, or we're at a plateau, or we already hit the peak? I'm looking for a little light at the end of the tunnel. If there's none out there, you can just be like, you're crazy.
Well, of course, today I'm super happy because we went 24 hours without having a positive person, and somebody testing positive.
Yeah, that's awesome.
But,
that's great news.
Yeah. I mean, I think that we're kind of holding steady right at the moment. And if we start to go down, I'll be so happy. I mean, I already kind of am, just in the fact that, again, I haven't had a positive patient, and if it continues, in that same trend, then that would be great.
Yes,
but I can't say for sure.
Okay. Chief, do you have any more questions?
No, I think I used up all the questions that I had allotted to me, but I was just curious.
Sam, I'd like to thank you for taking time out of your busy schedule to spend time here with us here in Roll Call. And for those who don't know, Samantha Lane is from the University of Maryland Charles Regional Medical Center. She's one of the infection protective specialists. Thank you, Sam.
Thank you.
Thank you, Sam. Appreciate it. Thank you.
Okay.
Thank
All
you,
right.
Chief.